This programming is brought to you by Boehringer Ingelheim Pharmaceuticals Incorporated. Heart failure guideline-directed medical therapy offers an opportunity to provide better care for patients, but significant gaps in uptake remain. Now more than ever, it's time to pump up GDMT for heart failure. Leaders in the cardiology community recognize this need and are asking you to do the same. Visit pumpupgdmt.com to learn more. Together, we can help ensure guidelines are enacted and patients receive quality care.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio nerds everywhere are working hard to fight this global epidemic. These are their stories.
Hey, cardio nerds. Welcome back to a case report episode. This is Amit Goyal tuning in from Dallas, Texas. But for this episode, we are flying over to Washington, D.C. to learn from our friends in Georgetown University. Y'all, welcome to the show. I think this is the first time each of you are on, so please introduce yourself to our audience.
Hi, everyone. I'm Merna Hussien. I'm currently a general cardiology fellow at MedStar Washington Hospital Center and Georgetown University. I did residency at Hopkins, and I grew in Cairo, Egypt, and I'm super excited to be recording this episode with everyone here.
Hey everyone, super excited to be here. My name is Abhinav Saxena. I'm currently a first-year fellow at Stony Brook University up in Long Island. I went to med school at St. George's University, and I did my internal medicine residency in chief year at MedStar Washington Hospital Center. I just graduated this past year. I grew up in upstate New York, and thank you for having me on.
Hey everyone, my name is Akhil Kallur. I'm also a first-year fellow at Stony Brook University in cardiology. I also went to St. George University for medical school, and I stayed in MedStar Washington Hospital Center to complete my residency and do an additional chief year. I'm from Markham, Canada. Thank you all so much for having me today.
Hi everyone, my name is Brody, and I'm absolutely stoked to be here with everybody. I use they, them pronouns. I did my medical school in India. After medical school, I moved to Mayo Clinic, Rochester, and subsequently to Stanford for postdoctoral fellowship. Thereafter, I moved to Washington Hospital Center for residency, and I'm a rising PGY3 applying to cardiology this cycle. Outside of clinical work, I'm passionate about LGBTQI plus cardiovascular health, especially in BIPOC community. In my leisure, I love listening to and practicing Hindustani classical music. Thank you so much for having me here.
Brody, Merna, Akhil, Abhi, it is such a pleasure to have you guys on. Y'all together represent such a range of training levels and experiences, so can't wait to learn from you. I used to love visiting DC when I was a resident in Baltimore, so I'm so excited to be here and hang out with you guys, and curious where you are going to set the scene for our discussion.
Thank you so much. I'm sure everyone who has visited DC has seen the government monuments and the museum, but today let's just take you to Rock Creek Park, which is a patch of green in DC. Sitting under a tree with cold breeze blowing is where we will discuss our amazing case.
What a wonderful backdrop to discuss cardiology. I have not been here before, so this is awesome. Let's get into it.
Our patient is a 67-year-old female who presented with new onset and progressively worsening exertional dyspnea over the past 5 weeks, accompanied by orthopnea. She also reported anorexia, nausea, and unintentional weight loss of 5 pounds during the same period. Notably, denied chest pain, palpitation, cough, pedal edema, fever, or chill.
That's definitely a concerning presentation, Brody. Does she have any past medical history?
Yes, Merna. He had hypertension and hyperlipidemia. Both were controlled with hydrochlorothiazide and simvastatin, respectively. He also had bilateral hip replacement at age 57.
That's interesting. Anything else on her other histories?
Sure, Akhil. No significant family history of cardiorespiratory illnesses or autoimmune condition. Socially, she's retired, lives with her husband. He's functional at baseline. He has no relevant travel or exposure history, does not smoke, drinks occasionally, and has no history of any other recreational drug use.
Thanks, Brody, for walking us through the history of the patient. So to summarize, this is a middle-aged female with a past medical history of hypertension, hyperlipidemia, and bilateral hip replacements who presents with subacute worsening exertional dyspnea, orthopnea, and constitutional symptoms. Although the constitutional symptoms point towards something systemic, the dyspnea really localizes the symptoms broadly to the cardiorespiratory system. Brody, can you walk us through your diagnostic approach to dyspnea?
Sure, Akhil. Happy to do so. As a previous CP Solver member, I would be remiss not to highlight their wonderful schema for dyspnea. Dyspnea, in general, can be from a variety of causes, which include cardiac, pulmonary, neuromuscular, hematological, and finally miscellaneous causes. Following that, it's important that we ask questions further characterize the dyspnea. The exertional nature of our patient's dyspnea, along with the orthopnea, narrow it down to the cardiac system. In fact, orthopnea has a reasonable specificity of 60 to 70% for heart failure.
That's really good to know. Which questions do you ask to really increase your pretest probability for heart failure?
Right. Personally, the three other questions I like to ask are the number of pillows that they use to at night, which is something you can track over time. In addition, I also ask about paroxysmal nocturnal dyspnea and bendopnea. For paroxysmal nocturnal dyspnea, I ask, do you wake up in the middle of the night gasping for air? And for bendopnea, I ask, do you feel short of breath when you bend down to tie your shoelaces? The reason I emphasize these symptoms is because these activities are associated with elevated filling pressure and therefore increase our pretest probability for heart failure.
Yeah, those are all great questions to ask. And with all that being said, how do you break down different etiologies of heart failure?
That's a great question, Abhi. For this, I tend to use the amazing framework that CardioNerds themselves have put out, which include the various etiologies are pump failure, valvular failure, electrical failure, coronary renal, finally pericardial failure. In the context of our patient, the ones that are on the top of my differential list include pump failure, valvular failure, and pericardial failure. The absence of chest pain and palpitation push coronary and electrical failure slightly lower down in my differential diagnosis list.
Yeah, that was a great breakdown. Thanks, Brody. So just curious, what else did you find on our physical exam?
On presentation, our vital signs showed a temperature of 37.5, a heart rate of 114 beats per minute, a respiratory rate of 20 beats per minute, and a blood pressure of 92/64 with a MAP of 73 and an oxygen saturation of 93% on 2 liters of nasal cannula. The cardiopulmonary examination noted elevated jugular venous pressure to mid-neck at 45 degrees, bivascular crackles with scattered expiratory wheezing, and cool extremities with a delayed capillary refill. There were no murmurs, gallops, friction rubs, or peripheral edema.
Oh, wow. So this patient's exam is highly concerning for cardiogenic shock with a wet and cool phenotype. What did her labs and diagnostics show?
Her CBC was unremarkable. The metabolic panel was notable for high anion gap metabolic acidosis, which was secondary to a lactic acidosis of 5.1. Her high sensitivity troponins were marginally elevated with a peak of 374. NT-proBNP was elevated to 7,124. Thyroid function was normal. To review the diagnostics, the EKG showed sinus tachycardia at a rate of 120 beats per minute with left axis deviation, right bundle branch block, and occasional PVCs. It is also notable for low voltage. The chest X-ray showed an enlarged cardiomediastinal silhouette and pulmonary venous congestion.
Wow, thanks, Brody. I do think the elevated lactic acid and liver enzymes in the setting of the vitals, as well as the sinus tachycardia and the relatively low pulse pressure, support our prior concern for cardiogenic shock in this patient presenting with heart failure. As I'm now thinking about what can cause this cardiogenic shock and to use the great framework you brought up earlier, I agree. I'm less concerned about coronary failure given the low level of high sensitivity troponin, the lack of chest pain or ischemic EKG changes, and the chronicity of her symptoms. I am, however, worried more about a pericardial failure or process given the low voltage on the EKG, along with the enlarged cardiac silhouette on the chest X-ray. I'm sure you have other things that made it to your differential diagnosis for this patient. Do you mind sharing that with us?
Absolutely, Merna. I agree with you regarding your concern about a pericardial process such as cardiac tamponade resulting in obstructive shock. I'm also highly concerned about pump failure secondary to non-ischemic cardiomyopathy. With respect to the causes of this non-ischemic cardiomyopathy from the presentation so far, I'm considering subacute myocarditis, cardiac sarcoidosis, given the enlarged mediastinal space, and other inflammatory cardiomyopathy secondary to autoimmune diseases. cardiac amyloidosis, especially ATTR amyloidosis, is certainly possible given her age, although it might present slightly later and with preserved ejection fraction unless it's end stage, at which point we call it burnt out. I'm also considering stress cardiomyopathy. While I agree that ischemic cardiomyopathy is less likely given her symptoms, but because of her age and other risk factors like hypertension and hyperlipidemia, I think it is something that we do have to rule out. Finally, given the constitutional symptom, cardiac masses, especially cardiac lymphoma, is also a diagnosis which is on my mind.
That was great, Brody. Thanks for bringing back the constitutional symptoms. I agree. We shouldn't rule out any malignancy or inflammatory process causing that, although sometimes just our patients presenting with heart failure can have cardiac cachexia for multiple reasons. You certainly did hit all of the top diagnoses I was thinking about, listening about this patient story. Though for our next part of diagnostics, I think, Akhil, if you can share with us if we got a transthoracic echo and what did that show?
Absolutely. So the transthoracic echocardiogram showed normal left ventricular size with borderline concentric hypertrophy, severely reduced systolic function with an EF of 20 to 25% with no regionality, and the RV systolic function was moderately reduced. So the echo also showed a moderate circumferential pericardial effusion without signs of tamponade. But for the degree of the size of the effusion and there not being any signs of tamponade were somewhat slightly surprising. So Merna, would you mind telling us about some signs of tamponade on echo?
Sure thing. It's a great question that we learn early in cardiology fellowship, and you'll get across it, is the size is not actually what matters. What matters most is the rate at which that fluid has accumulated. And the way I think about it is that if you have an acute accumulation of pericardial fluid, it's going to stretch out that pericardium pretty quickly, and the pericardium is going to reach its elastic limit. But if it happens slowly, the pericardium can sort of accommodate more fluid before it reaches that limit. But once you reach the elastic limit, the pressure in the pericardial sac starts to rise. And as it rises, it's going to start tamponading or compressing the chambers that are at least pressure. So thinking about that, the first chamber that would be, it's the right atrium at early ventricular systole. And then it will be the right ventricle at early ventricular diastole. So if you're thinking of an early sign of tamponade that is sensitive, it would be the systolic collapse of the RA. And a more specific sign, it would be the early diastolic collapse of the RV, which were absent in this patient. Although she did have a 1 to 2 centimeter sized effusion, which is a moderate size. That's one thing. He's looking for chamber collapse, whether it's the RA or RV. And obviously, if it's much higher pressures, you can even get the LA and the LV. But another thing to think about is now you have a limited space in a stretched fluid-filled pericardium. So the ventricles are sort of fighting over that space, and you get what's called ventricular interdependence. And we see that on echo with respiratophasic variations in the mitral and the tricuspid inflow velocities. For example, inspiration, the tricuspid inflow velocity would increase, and the number two members 40% or that, and would respectively decrease in the mitral inflow by at least 25%. So that's the second thing to look at. One quick way to try to rule out tamponade is sort of looking for your IVC. And a plethoric IVC is a prerequisite for tamponade, given how you have limited ventricular filling. So in this case, we didn't have chamber collapse and we didn't have respiratophasic variation. We did not think that she had signs of tamponade by echo. But it would be interesting to see what was done about this effusion for this patient, whether they drained it and whether her hemodynamics changed at all with that.
Thank you so much for that, Merna. So, Abhi, do you want to give us the findings on the table of truth?
Yeah, absolutely. So the left heart cath did not show any significant CAD, which once again matches our pretest probability of low suspicion for ischemic cardiomyopathy. With respect to the right heart cath, numbers were as follow. The right atrial pressure was 15, RV 45/20, PA 45/25, the wedge was 30, LV EDP was 30, cardiac index was 1.7, and some of the derived metrics we have were the PAPI of 1.3 with a PVR of 0.5, and the right atrial pressure to wedge ratio was 0.5. SVR was 1,498, and the cardiac power output was 0.5.
Abhi, these numbers sound concerning. How would you interpret these given the patient's clinical picture?
Yeah, I definitely agree. So There's definitely a low cardiac output with bilateral elevated filling pressures and post-capillary pulmonary hypertension. And one thing that Merna commented on was the no echocardiographic findings of tamponade. And however, here we don't see any equalization of the pressures in the chambers, which is sometimes seen in severe tamponade physiology as well too.
Well, it's at least somewhat reassuring to know that given the size of her pericardial effusion, there was no evidence of tamponade. So what happened next for this patient?
So she was started on dobutamine 2.5 for support. However, she continued to have worsening hypotension and tachycardia. Her repeat echo then showed signs of tamponade physiology, so a pericardial centesis was performed. At that time, 575 milliliters of serosanguinous fluid was drained, which was sent for histology.
That's a great point of how hemodynamics are dynamic. And when she didn't have tamponade initially, serial evaluation is important. And it sounded like we were then concerned for tamponade. It'd be interesting to know, how did her hemodynamics then change after they removed such amount of fluid?
Yeah, so post-drain, she was diuresed and maintained on dobutamine 2.5. During that time, further non-ischemic workup was sent, and that demonstrated a normal SPEP and UPEP and IFE. Room labs were also normal with normal complements, ANA, SSA and B, and ACE levels. Ferritin, zinc, and thymine levels were also within normal limits as well too. In addition, as part of the workup, she had a cardiac MRI, which demonstrated diffuse LGE throughout the LV, suggestive of cardiac amyloidosis. There was also severe LV global systolic dysfunction and moderate to severe RV systolic dysfunction as well too. Merna, since you're a fellow, do you mind walking us through your framework for understanding and interpreting cardiac MRI?
Wow, absolutely, Abby. I am a fellow, but I'm no means an expert on cardiac MRI, but I'll share with you how I think about it. So cardiac MRI is a great tool to accurately evaluate a chamber size and function, and without using radiation. And my understanding is we do use different sequences of rate geofrequency pulses that the tissues react to it differently and send a signal back. Depending on how the signal comes back, you can evaluate different tissue characteristics. And then when you add to that MRI contrast, which is gadolinium, it can give you more evaluation of the intracellular space, because gadolinium is a heavy metal that diffuses freely between the intravascular and interstitial space, but it does not cross into the intracellular space. So if there's anything that's causing scarred or inflamed myocardium, it's going to increase the extracellular space in that area, so gadolinium will hang in there, and that's what we call late gadolinium enhancement. So you combine what you see on the MRI from the structure, function, late gadolinium enhancement patterns, along with different sequences like T1, T2, T2 star in some cases. You can try to find different etiologies for non-ischemic cardiomyopathies. And sometimes, too, you can evaluate if there was an ischemic process that happened and wasn't caught earlier. So in this case, it sounded like our cardiac MRI readers were concerned for cardiac amyloidosis, and that's particularly because of the scattered diffuse LGE, the T1 time, and something called the nulling of the gadolinium compared to myocardium, which are more suggestive of cardiac amyloidosis. So that's how we got to that suggestion.
Given the diffuse late gadolinium involvement and high suspicion for cardiac amyloidosis, I wonder if our next step should be an endomyocardial biopsy. Akhil, do our patient get an endomyocardial biopsy?
Absolutely, Brody. I definitely agree and think the patient should get a biopsy. The real indications are when you're trying to diagnose non-ischemic cardiomyopathy of unknown etiology, and it's also useful in diagnosing various forms of myocarditis, amyloidosis, storage diseases, and sometimes even cardiac masses if they are amenable to a biopsy. The yield for cardiac sarcoidosis, although, is about 20 to 30% due to its patchy nature in disease involvement. It's also performed routinely after a cardiac transplant to rule out any kinds of evidence of rejection. So with our patient, she has a rather fulminant presentation, which is rather uncharacteristic of cardiac amyloidosis. And cardiac amyloidosis is not a diagnosis that necessarily needs to be supported with an endomyocardial biopsy. There are other methods in which we can make that diagnosis. So due to this patient's presentation being somewhat unclear, does this patient really need a biopsy? And in that situation, I would actually agree and argue for it. So Brody, did the patient get a biopsy? And if they did, what did it show?
The patient did get a biopsy, and it showed the following findings. It showed myocyte hypertrophy, focal interstitial fibrosis edema, and focal mild lymphocytic infiltration. It did not show any granuloma or amyloid deposits, which are also tested for with Congo red stain. It was reported to be chronic cardiomyopathy with focal physiological changes consistent with lymphocytic myocarditis. In addition, the pericardial fluid, which was also sent for analysis, was negative for suspicious malignant cell or infection. Furthermore, given the presence of mediastinal lymph node, a lymph node biopsy was also done, which did not show any granuloma.
Oh, that's interesting. So it's not cardiac amyloidosis. I wonder what else could mimic the same presentation.
Yeah, that's the question. We haven't shared this earlier, but our wonderful advanced heart failure team had an earlier suspicion for a rare cardiomyopathy, especially given her history of bilateral hip replacements. So they directed us to send cobalt levels, which came back a few days later to be significantly elevated at 121 micrograms per liter. The normal is less than 1.
That's definitely a plot twist. Can cobalt really cause cardiomyopathy?
Yes, it sure can. It can spill from the hip prosthetics into the blood and is just toxic to the myocytes. It is exceedingly rare, but as Brody shared earlier, can be diagnosed with an electron microscopy evaluation of the myocardial biopsy tissue, which was done in this case and showed mitochondrial changes concerning for cobalt toxicity. When that happens, you also need to evaluate the source of the cobalt spillage. So an MRI was obtained of the hip replacements, which did show abnormal periarticular soft tissue of the left hip and complex fluid in the left iliopsoas bursa, consistent with pseudotumor formation. So when you combine the biopsy results with the hip MRI, they together seal a diagnosis for cobalt cardiomyopathy for our patient.
Wow, this is really an interesting case and such a unique diagnosis. Akhil, do you know what happened next with our patient?
Absolutely. So, firstly, there was a multidisciplinary discussion that happened, and the patient underwent revision of the left cobalt alloy hip prosthesis with the ceramic hip prosthesis. The patient was then placed on oral N-acetylcysteine chelation therapy and discharged with a continuous dobutamine infusion. At the 1-month follow-up clinic visit, the serum cobalt levels had declined to 33.1 micrograms per liter. However, her repeat echocardiogram revealed persistence of severe LV systolic dysfunction. Unfortunately, the patient was readmitted to the hospital with worsening heart failure symptoms and needed an additional inotrope with milrinone. Her serum cobalt levels further decreased to less than 11 micrograms per liter. For our SCAI Stage D cardiogenic shock patients, she was evaluated for an expedited heart transplant workup and received a successful orthotopic heart transplant. Electron microscopy of the explanted native heart showed cardiomyocytes with large lipid-laden droplets and enlarged distorted mitochondria. Myocardial tissue cobalt levels obtained from the native heart were elevated at 0.95 micrograms per gram, and the reporting limit for this is less than 0.018 micrograms per gram, which was consistent with our diagnosis of cobalt-induced cardiomyopathy.
Guys, I am so glad the patient is doing better. It's definitely a rare presentation of something that's so relatively common. There are millions of people who get joints replaced in the US. Truly a humbling experience. I guess we can talk more about cobalt cardiomyopathy in more detail. So, Avi, do you want to walk us through the presentation of cobalt cardiomyopathy?
Yeah, of course, Merna. So there are various effects cobalt has on both the heart microscopically and biochemically. Interestingly, it's actually not an infiltrative disease, and the severity of cardiac dysfunction does not correlate with the serum cobalt levels. Cobalt has multiple calcium-mediated cardiac effects and may also interfere with TCA and ATP generation by the mitochondria. On histology, we see similar findings to what we saw in our patient, which is usually a modest change with no inflammatory response on microscopy. However, we see ultrastructural changes, including ventricular degeneration, swollen and distorted mitochondria with loss of cristae. Akhil, as the only Canadian here, do you have any interesting facts to add?
I absolutely do. I'd love to educate people about Canada. So interestingly enough, for a period in the mid-1960s, cobalt was a frequent additive to beer in Quebec for foam stabilization, and a case series of cobalt cardiomyopathy was seen among heavy beer drinkers. The article is actually very fascinating and is called Quebec Beer Drinkers Cardiomyopathy. The most important exposure nowadays is in joint arthroplasties, which often use cobalt chromium alloys due to their hardness and durability. Metal-on-metal implants are the highest risk factors due to contact wear and the release of nanoparticles. The diagnosis is made with consistent history. The cobalt level should be elevated, but the severity of the disease does not correlate well with the levels of cobalt. MRI can show an infiltrative pathology, and native heart pathology is often diagnostic. Merna, do you want to walk us through the management of cobalt cardiomyopathy?
Of course. So for just the cardiomyopathy or the heart failure, the medical management still includes guideline-directed medical therapy. And for the cardiogenic shock presentation, it would be similarly to our other patients presenting with cardiogenic shock. So supporting them with inotropic support, mechanical circulatory support, and evaluating those who need durable LVADs or transplant when appropriate. But for the cobalt cardiomyopathy, you can also consider oral chelating agents, but the mainstay of management is just removing the source of the exposure, which in this case were the hip prosthetics. And cobalt cardiomyopathy is rare, but sometimes a serious condition as seen in this patient. So it truly underscores the importance of taking a thorough history and considering uncommon etiologies for common symptoms. And to me, I do really think that I learned a lot about recognizing the clinical and imaging features of heavy metal toxicity and using different multimodal imaging and the importance of talking to different teams and getting a multidisciplinary approach in managing such complex cases.
Thank you, Merna. This is such a fascinating and sobering case. Some of the teaching points for this case include that a good history goes a long way in the diagnosis of non-ischemic cardiomyopathy. Common problems can have uncommon presentations that require a high degree of suspicion to make the diagnosis. The radiological histological signs can overlap between the causes of non-ischemic cardiomyopathy. However, history helps us in further focusing our diagnostic to uncover the root cause. And finally, multidisciplinary effort is absolutely essential in making a rare diagnosis like cobalt cardiomyopathy. It was such a pleasure to be on the show to share this case with the CardioNerds and with our listeners.
Thanks, Brody. This was a really fun case to explore and dissect through together.
Absolutely. It was extremely educational.
I totally agree. Thank you, everyone.
Y'all, this was such an awesome discussion. Thank you so much for teaching all of us. This is such a great example of why cardiology is so amazing. So much phenomenal multimodality imaging ranging from cardiac MRI, invasive hemodynamics, coronary angiography, but really ultimately the diagnosis came down to an excellent history and good diagnostic skills. So thank you so much for sharing the awesome work y'all have done for this patient. We're so lucky to be able to learn from your story.
And for the expert commentary, I want to introduce Dr. Nana Afari, who's one of our advanced heart failure specialists at MedStar Washington Hospital Center. Dr. Afari went to medical school at George Washington University, and he completed his internal medicine residency and cardiology fellowship at Temple University. And then he went to MedStar Washington Hospital Center for advanced heart failure and transplant cardiology. In his practice, he treats the spectrum of patients that come through the door, from advanced heart failure diagnoses to care ranging from medical therapy to LVADs and cardiac transplantation. But he does have a special interest in patients with amyloidosis and other forms of infiltrative cardiomyopathies.
Hello, everyone. I feel privileged to join in this discussion, and I first want to thank the team for including me. This is quite an exceptional group of resident cardiology fellows and overall my future colleagues in our field. This was a complete and thorough overview of the case with a stepwise and systematic approach to our patient's presentation, workup, and eventual diagnosis. I could not have done any better, so I thank you for allowing me to add my 2 cents. Heart failure with reduced ejection fraction, which is defined as a left ventricular ejection fraction of less than 40%, accounts for a significant proportion of patients admitted to the hospital with clinical heart failure diagnosis. The diagnosis of heart failure comes with it considerable morbidity and mortality, despite the many advances which have been made in treating our patients who have the disease. Dilated cardiomyopathy is defined by the presence of impaired myocardial contraction involving either one or both of the ventricles. A vast majority of these are considered idiopathic, meaning no primary or secondary causes of heart disease were identified. However, it is highly probable that within this category lie many of these rare cardiomyopathies. I cannot emphasize enough the importance of obtaining a complete history and physical examination, something that is ingrained, of course, in all of us through our training, and having a heightened awareness of some of these rare cardiomyopathies, such as in this case. Although a trace element, cobalt is widespread And nowadays, it is not that unusual to find it in metal-on-metal prosthesis. In hip arthroplasties, these types are unfortunately known to have higher failure rates, which lead to the release of ions within local tissue and the bloodstream. In fact, the levels of ions in the bloodstream are sometimes used to detect failing metal-on-metal hip prosthesis. As a divalent cation, there is some similarity between cobalt and calcium, so it is not surprising that a proposed mechanism of cardiotoxicity may be related to cobalt-induced changes in calcium handling or calcium transport, most of which occur within the mitochondria. There have been many case reports of cobalt-induced cardiomyopathy due to hip arthroplasties. However, without obtaining the history of metal-on-metal arthroplasty, there is no way to hone in on this entity. The clinical presentation, which was well described by the team a moment ago, are the typical symptoms you would expect to see in patients with symptomatic acute systolic heart failure. And dependent on the advanced nature of the cardiomyopathy, evidence of low cardiac output such as cachexia, early satiety, weight loss may also be apparent, as was seen in this case. What's important for us as clinicians is to exhaust all available avenues in order to identify the possible etiology of our patient's cardiomyopathy, as this may dictate the use of available treatment options. In the case of cobalt-induced cardiomyopathy, identifying an elevated blood cobalt level in the setting of cardiomyopathy should raise a high suspicion for the disease process. But it is important to note that the level of cobalt within the blood does not necessarily correlate with the severity of cardiomyopathy. In fact, it seems that cardiotoxicity can occur in any degree of blood elevation of cobalt ion. If identified early on and prior to irreversible changes occurring within the myocardial tissue, and of course with appropriate treatment, which may include surgical revision of the prosthesis or chelation therapy, as highlighted in our case, many patients with this rare disease entity can have improvement in their cardiac function. In select patients who do not show improvement in their cardiac function and remain with advanced cardiomyopathy, therapies such as heart transplantation and durable ventricular assist device may be an option. As an advanced heart failure cardiologist with an interest in inflammatory and infiltrative cardiomyopathies, the systematic approach used to reach the diagnosis of this case was exemplary and in course with what I would expect from such a stellar team, systematically ruling out the common infiltrative diseases such as cardiac amyloidosis and cardiac sarcoidosis, and more importantly, not accepting the negative Congo red staining on endomyocardial biopsy, as well as a negative lymph node biopsy as the end of the investigation process, speaks to what we can all aspire to do as clinicians. The extra step of requesting electron microscopy of the tissue helped cinch this diagnosis. It has truly been my pleasure to join the team in this discussion as we continue to learn from each other. Again, my name is Afari Armah. I am an advanced heart failure cardiologist at the MedStar Washington Hospital Center, and I thank you for your time and attention.
Thank you so much for tuning in to this CardioNerds episode. The audio editing for this episode was performed by me, Christiana Dangas. I'm an intern in the CardioNerds Academy and a senior at Boston University. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and split.